ago, Lydia, Bartholow, my colleague, and I are going to talk to you a bit about what we call trauma-informed chronic pain care. So these are our learning objectives for today. We'd like to provide you with, I really like, I'm very reductionist, I like mechanics of how things work. So we're trying to provide you a neurobiological framework, or really more of an explanatory model, not a solution, but an explanatory model for our patients who may be experiencing chronic pain, addiction, and trauma. To do so, we're going to try to help you to understand new concepts in the neurobiology of addiction and chronic pain and how they align, and then lead into an understanding of the neurobiology of trauma and how that may exacerbate symptoms of pain and addiction, and then finally discuss aligned treatment modalities, both pharmacologic and behavioral, for this triad of conditions, including medications you might want to avoid in this population. Okay, so first, welcome to primary care. So just a little background here. Lydia and I work together at the Old Town Clinic. We sit in the same team room. I would often hear her talking about the neurobiology of trauma, or talking on the phone to a patient who was also my primary care patient, and I was like, oh my gosh, these share so much in common. So would it be interesting if we tried to unpack some of our more multifaceted, I'll try to stay away from the word complex, some of our more multifaceted chronic pain patients that we see in primary care, and look at it from different perspectives. So in case in the past 16 hours you have forgotten what such an experience of trying to think you can solve or fix a patient like this in a 20-minute visit might look like, we've got a little video to remind you. Oh, Bill, did I do it right? No, I knew I wouldn't be able to do it. This one? So I'm afraid if I press the wrong thing, that the whole thing will explode. See? Ideally, there's sound. Or I'll hold your coffee, Phil. Sorry, guys.
while they're working on this, I'm just going to jump in and try to fill in some time because it occurs to me that the question, so my name is Lydia Bartholow. I'm a Psych MP at Old Town Clinic, and then I'm dually certified in addictions medicine. And so I'm just going to jump in while they're trying to figure this out, although we just may not have our hilarious video for you all today, unfortunately. So it occurred to me, someone asked the question, what is trauma-informed care? And Rachel and I call our talk trauma-informed care, but we never actually defined that. Are you just going to skip the video? Darn it. Okay. So we'll come back to trauma-informed care then.
Okay. Anyway, this will be an opportunity. Maybe, Lydia, we can improv something a little later, but at the very least, we can send you out the videos. I will say, in the interest of trying to sort of explicate what happens in the video, it's really, I think, as well-intentioned primary care providers, patients with a very complex set of symptoms can often start telling you one thing after another. We're trying to catch up. We're trying to think we can manage it. We're trying to think that we can kind of approach this with a biomedical framework that we've been taught to do a review of systems and ask what makes it better, what makes it worse. Before you even get to your first of those questions, this person is in a lot of distress and is going on to the next thing, and you're still trying to catch up. So that's the essence of the video. Anyway, I will contain my sadness. So here's what we wanted to describe for you, though. What I'm going to try is to give you a sense of how and Jim alluded to this in his talk, how centers of emotion and reward in the brain start to play a much larger role in chronic pain. So this is a study also which Jim alluded to, which shows that for a long time, pain research focused on how sensory systems change and become amplified as we move from acute to chronic pain. And this is true when it still occurs, but we also know that with persistent pain, sensory changes are important, but also modifications in emotional and reward processing become much more predominant. So this study, just using fMRI at the beginning of injury, which is people with the SBP, the subacute back pain, and then doing an MRI of the same person 3 months into their pain complaints, and you can see that the brain regions that were activated in earlier stages of injury really start to change from those of pain to those of emotion and reward as we get later into injury. So what are the reward circuits? What does that mean? Well, I think in order to understand it better, it's really helpful to revisit the neurobiology of reward and emotion, which is elegantly described in the Neurobiology of Addiction by my hero, Dr. George Koob, who someday will come to Portland, I'm hoping. So on this slide is what George Koob calls his life's work. It's everything that you need to know about addiction. And as Dr. Koob says, the addiction circuits have color-coded themselves for you to make it a little bit easier to understand. So I'll just walk you through them one by one. As an overview, the blue circuits you see up there are the binge intoxication stage. That's the fun part. The red is the withdrawal or negative affect stage. And the green is where your frontal cortex comes in. It's the craving stage. It's what George Koob calls what makes us human in addiction. So first let's talk a little bit about the binge intoxication phase. And here the basal ganglia really play a key role. Basal ganglia meaning the nucleus accumbens, dorsal striatum, globus pallidus, projecting up into the thalamus. And when these areas are stimulated, you get the fun part of substance use. You get euphoria, you get intoxication, but also you get this interesting concept called incentive salience. And incentive salience is sort of more the wanting. It's not the liking exactly, it's not the pleasure of binge and intoxication, but it's that motivational, magnetic quality of some particular stimulus that makes it a desirable or attractive goal. And what becomes interesting in addiction, and we'll see this in pain as well, is that these stimuli can begin to reinforce themselves and can be triggers in and of themselves. So the example that George Koob uses is this idea of a stimulus, just the cueing, the wanting, being a trigger in and of itself, comes into play when you would do those just say no to drugs, and they would show these really gory images of people injecting in bathroom stalls, and those actually didn't disincentivize people to use. They were actually triggering this reward system and triggering craving. Dopamine, which we'll talk about a lot in the next few minutes, plays a really key role in incentive salience. It really influences the priority or the level of desire that of such a stimuli to a given person. And this will play a really key role in pain, which we'll see in a second. Oh, I'm still getting over the video sadness. Sorry if my dysphoria is on. I'll get past it. Okay, take it out. So just another word about the nucleus accumbens. Again, sort of the key part of this reward system, which we'll learn more about in a second, sits in the ventral part of the basal ganglia. It's what George Kuhn calls the grand central station of reward. Everything converges there, particularly our primary neurotransmitters, dopamine, opioids, and then all of the other drugs of abuse that can act upon them. The nucleus accumbens is the part of our brain that integrates information to get us what we need for survival. It's where we form habits and mediates how we process rewards. So when the nucleus accumbens is in its blue happy phase, it's projecting up into those other structures I just showed you, and you're getting that euphoria associated with a particular drug. But what happens in addiction is that things go from that more euphoric side to what George Kuhn calls the dark side of addiction, or the withdrawal or negative affect stage. And in this slide, then, you'll see the nucleus accumbens has changed color, which doesn't actually happen, but it's helpful to look at. It's changed color from blue to red. It's sort of lost its reward function, and it's gained stress function, and now is projecting down rather than projecting up into the rest of the basal ganglia. It's projecting down into the amygdala, that structure deep in your temporal lobe that mediates anxiety, irritability, fear, fight or flight. So what happens as you become more dependent on a drug, the nucleus accumbens loses its reward function and it gains stress function in the amygdala. Basically, the idea being that what goes up must come down. There's going to be payback in your brain when you overdo your reward circuits. So here's a nice conceptual model which helps us to understand this a little bit better. This is from a psychologist, Richard Solomon. It's what he calls the opponent process. So, can't see from back here, but on your left is in a non-dependent individual when they use a substance. Oh, sorry. So in this process, the A, where it says A, that's feeling good, and B is feeling bad. And so in that left-hand panel, when you're not dependent on a substance, let's say you go to a wedding or something and you drink and you have a peak at A of feeling good, and the next day you may have a little hangover, a little effect of B, but you're going to get a pretty rapid return to baseline, and you're going to feel better after a little while. But on your right-hand column, on your right-hand side, when somebody is dependent on a drug, that A process is largely suppressed, if not gone altogether. And what you're experiencing when you use a medication is very little of that euphoria, and much more you're feeling the withdrawal effects when you don't have it. A much more profound trough, I guess, in B, with a slower decay and a slower return to baseline. So what is the B process? What causes that negative affect in addiction, and what, as we'll see later, in pain, and actually in trauma as well? Well, it's a couple of things. One element of the B process is that you lost your reward neurotransmitters. Nora Volkow, who's the head of NIDA, has done lots of studies showing that after 3 months or so of use of an addictive substance, your dopamine receptors will light up a lot. You'll see fewer dopamine receptors on an fMRI. So you're just not getting as much input from a lot of your reward neurotransmitters, namely dopamine and opioids, and their helper neurotransmitters, serotonin and GABA. So just the opposite, just the absence of those in and of themselves make you feel lousy. The absence of dopamine gives you dysphoria. The absence of opioids gives you pain. The absence of serotonin also gives you dysphoria. The absence of GABA makes you feel panicked and with anxiety. But kind of the cruel thing in addiction is that not only in that B process do you lose those reward neurotransmitters, but you recruit a whole new set of anti-reward neurotransmitters, which are who I think affectionately calls the bad guys. And these are neurotransmitters that you might not see as much otherwise if you're in sort of a euthymic state. So one is dynorphin, which is sort of the cousin of opioids. It's actually an opioid peptide, but rather than making you feel good, it makes you feel profoundly dysphoric. The other is corticotrophin releasing factor, which can make you feel a great deal of stress, as well as norepinephrine, which can make you feel a lot of stress. So these are actually activated in the amygdala and the ventral striatum during withdrawal. So kind of a double whammy is the point. So finally, in addiction, again, we're going to see this in the other two conditions as well, is the neurocircuits of sort of your frontal cortex, which can really lead to preoccupation and anticipation of using a drug or getting any kind of relief. And in addiction, what we see is really a decreased functioning of these systems. These really help you with stop and go. They can help to regulate some of these other when functioning can help to regulate some of those other reward and limbic systems. But in addiction, they become impaired, and it's kind of a vicious cycle. You take an initial drug, that in that sort of clouded state, it causes some impairment in your executive functioning. That causes some escalation of further drug intake. That actually causes more profound neuronal cell death, which causes low functioning or impairment, sort of hypofunctioning or impairment of your prefrontal cortex, which then causes you to use more, and it becomes this vicious cycle. A vicious cycle where the executive functioning is really less able to exert any control over your reward and limbic systems. All right, so that's the quick 5-minute review of addiction, and we'll see how closely it aligns with, or maybe is very similar to, or difficult to extricate from pain. So how does this relate to pain? Well, I was able to see this really interesting pain substance use disorder researcher at a conference recently named Jody Trafton from Stanford. And what she talked about really blew me away in its alignment with addiction. So I wanted to share it with you today, because I think it helps put some of these pieces together of this video that you did not see. So in Jody's view, she sort of boils this down a little bit differently, but looks at the reward system in pain as this ability this system where we make quick decisions is the reward system. And she breaks it down to sort of a 3-neuron circuit. And what this circuit does is it helps you to predict opportunities for reward. What's going to make you feel better in 10 minutes than you feel now? This system doesn't care about how you're going to feel tomorrow or next week or next month. It cares about how you're going to feel in 10 minutes. And it finds those opportunities and then drags you to them. So all of these circuits release dopamine. So the 3 neurons that she talks about, just in this boiled down system, one are the dopamine neurons in your ventral tegmental area, which you can sort of see there on the right. Its job is to go out and find opportunities that are going to make your life better in the next 10 minutes. It finds those opportunities and then it makes a guess or an estimate of how much reward you will get if you take advantage of that opportunity. The ventral tegmental area then sends that information over to the nucleus accumbens, which we talked about mediates our reward system. And the nucleus accumbens' job is to pay attention to those opportunities. And if the signal it gets from the ventral tegmental area is large, if it gets a big dopamine signal, it says, wow, this is going to be, we're going to get a lot of reward from this, go for it. And it tells the ventral striatum, go do that activity. Well, interestingly, the ventral tegmental area also sends projections up to the frontal cortex. And the frontal cortex is able to think more about those long-term goals. What is going to make me feel better tomorrow or in a month or in a week? But the problem is that our frontal cortex is really fancy, and so it's very slow. And in order for it to have control, you need to have the nucleus accumbens making decisions slowly enough so that the frontal cortex has time to step in and say, wait a minute, we don't think this is a very good idea, let's not do it, because we're thinking about the long term. But again, things need to be happening relatively slowly in the nucleus accumbens in order for the frontal. So, okay, so So how can this go wrong? This sounds like a pretty good deal. And it's true, the reward system is a good thing. It's crucial for our survival. But if it gets out of balance, if it starts to take over, it can over-influence our decisions. And you can wind up in a behavioral state where you appear impulsive, you appear driven by immediate gratification, you're unable to tolerate distress. So we've already seen that addictive drugs can dump a lot of dopamine into this reward system, but the search for pain relief can do the exact same thing. It can put lots of dopamine into these reward circuits and ultimately drive habitual, compulsive relief seeking. Okay, so here's what am I talking about? What does this actually look like in pain relief? Well, let's take the example of quick pain relief, the couch. So let's say that you have hurt your back and you're searching for relief from your acute pain from your back, and your ventral tegmental area sees that couch and it says, wow, this is an opportunity for quick relief. And it sends a big dopamine signal to your nucleus accumbens, and your nucleus accumbens says, that looks great, go for it, go lie down on the couch. And you do, and your back pain immediately feels better, and your brain then recognizes that reward. Well, your reward circuits learn this, and they start laying down the couch as a new context for relief. And so the next time you see the couch, your brain is sort of more likely to want to go lie down on it. But the problem is, sort of with all of these, when you sort of, like we talk about overdoing the reward system, the next time you lie down on that couch, you might not get that same level of reward. So you're going to search for the next stimulus that's going to give you a higher level of reward because you're continuing to seek that relief. Maybe that stimulus is taking your pain medication. Maybe it's taking more pain medication than you were supposed to or than you did the day before. So the idea here is that patients with pain and with injury are going to start getting attracted to situations where they get quick relief. And the longer you have that pain, the more you are continually attracted to those quick relief stimuli, which may start as lying down, but then may move to guarding, may move on to self-medication. What this means is that after injury in particular is a very vulnerable time. People are going to start to orient towards things very rapidly that may provide them with quick relief, but might actually not build their recovery. And this can be actually a very unconscious reinforcing process. Basically, in these times of acute pain and acute injury are when pain can really shape your reward learning circuits. So what happens over time with this becomes, again, even more deleterious. If you have chronic firing of dopamine in these reward circuits, it actually reshapes them and overall makes them very hard to control. How this works is you have two sort of subtypes of dopamine receptors in the nucleus accumbens. One is your D1 receptors. Those are excited by dopamine. If those are stimulated, those are more likely to trigger reward-seeking behavior. And then you have the counterpoint to that, which is your D2 receptors. They're actually more inhibited by dopamine. They slow your decision-making process. They actually increase the level of activation firing, in order, essentially pushing back the starting line, so it makes it harder to go do a behavior. They're your brakes, and they give your frontal cortex time to step in. But if you have dopamine neurons that are chronically overactive with repeated big surges of dopamine, they sort of recruit and make the D1 receptors the predominant actors. The D1 pathway itself becomes much more efficient. It speeds up your ability to make speeds up your decisions to seek quick relief. And at the same time, all of those anti-reward neurotransmitters that we talked about in addiction, when those, for instance, dynorphin and CRF and norepinephrine, those become activated when your reward system in pain is also speeding up and rapidly seeking relief. So again, you can see the vicious cycle here. The dynorphin is making your mood worse. The CRF and norepinephrine are causing more stress. Those in turn are amplifying your pain signals. Your pain severity is increasing and your relief-seeking behavior is only perpetuating. Again, becoming a somewhat compulsive, vicious, uncontrolled cycle. So this is, I think, a lot of when, again, if as you would have seen in the video, when somebody is seeking pain, oh, people, okay. When someone is seeking pain relief, and it seems that you can't really get them to sort of do what you are wanting them to do, you should go to physical therapy, it's because this process is happening and they're in this cycle of seeking quick relief. So we had these breaks, what happened to them? Well, basically your D2, your inhibitory pathway, actually becomes desensitized in the setting of big spikes in dopamine. Jody Trafton talks about it as sort of you slam on the brakes and then you cut the brakes. When D2 receptors are hit with the big dopamine surge, they actually internalize, those receptors get internalized, and they won't become active again until the receptor is kind of recycled in the cell, or a new one is actually synthesized. Oopsie. So you essentially end up with a system that doesn't have any brakes. So just to try to wrap up what I've been rapidly trying to tell you here, you can think of pain actually as an addiction-like state in a few ways. Both addiction and pain relief-seeking behaviors activate and overstress your reward system. In both addiction and pain, when the reward system is overactivated and anti-reward neurotransmitters are enhanced, or when the reward system is overactivated, anti-reward neurotransmitters in the limbic system are also enhanced, causing stress, negative affect, impulsivity, really compulsive behaviors that will make somebody do anything to keep from feeling so lousy. What's interesting also is that this has been observed not only with drugs of abuse, but also you can see the same process actually with processed foods, with foods that have high levels of fat, sugar, salt, things that aren't naturally found in food. And then in both addiction and chronic pain as well, the executive functioning of the prefrontal cortex is impaired, and it's then unable to exert control over the ventral striatum and the limbic system, overall preventing activities that would ultimately lead to recovery. So this isn't just theoretical, they've sort of looked at some of these systems and dopaminergic inputs, both in rats and humans. In rats, interestingly, if you block D2 receptors in rats, it's found that they'll have an increased place preference for opioids. They'll have a more rapid withdrawal from noxious stimuli. They'll have more anxiety. They'll go after sugar water more. Anything that will help people to give relief and to try to search for the next big dopamine signal. In individuals with dysregulated, or in people with dysregulated dopamine systems, you'll see people with these high dopamine surges will be more likely to progress from acute pain to chronic pain. People who use drugs that pharmacologically increase dopamine in the nucleus accumbens may be more likely to develop chronic pain syndromes. And they've also looked at both individuals who use tobacco, as well as people who use injured workers using high-dose opioids after acute injury. And those people as well are more likely to have persistent pain after initial injury. Okay, so that was to help you understand a bit some of what we see. Oh, here comes Phil. Okay, all right, so now retroactively. Now there's so much anticipation. It's like, that was so not. What a big deal. Okay. All right.
I just go by Rachel. We're really laid back here at the Safe Space Clinic. Last name is a total disaster anyways. And, this is Chloe, by the way. She's my companion pet. Oh. She goes everywhere with me. Okay. I'm not actually super into pit bulls, but that's honor your bringing things here. So I have a ton of questions I could ask you, but what's most important is what's important to you. So tell me, what brings you into safe space clinic?
Okay, well, I have a head injury, so I have my memory doesn't work very well, so I have a list here.
Oh, okay, okay.
Is that okay?
Yeah, yes, thank you, and it's so helpful. Oh, yeah, okay. Oh, wow, okay, so that's a pretty, that's a pretty long list there, so we've got about 20 minutes or so.
Well, I mean, there's a lot, and I need for you to get like a full picture of what's happening for me, otherwise you're not gonna really understand, so.
Okay.
Yeah, I don't know what's going on.
Of course.
So, first of all, I've been in like a lot of car accidents. I've had a lot of broken bones. I've got osteoporosis.
Have you tried?
It's degenerative. Yeah.
Really? I haven't heard of this. Okay.
It's so painful.
Okay. Any bones in particular? Is it your knees, your legs?
Well, I mean, I've got like,
discs in your.
I have degenerative discs in my back.
Okay.
I've got really bad neuropathy.
Oh,
If you could see my legs, they're like red and like the veins are sticking out.
Is it like a circular? Do you get cramping when you walk?
No. It's like I have arthritis. I have arthritis in my shoulder. My physical therapist says I need to like not go to the Sorry, this is really looking at the arm right now. I'm just like in a pain.
So tell me, what have you tried that helps for your pain?
In the past, I was on methadone for a while, and that sort of.
Was that at a methadone?
It was in a methadone clinic. I did that for a really long time, and then I was like,
How did you get into the methadone clinic?
It was for pain. I went for pain, so it didn't feel
Did you
appropriate.
ever use any injection?
No, I mean, not really. I needed pain management, and that's what they wanted me to do. So.
Okay.
Anyway.
Usually that's more for. Okay.
Anyway, I left it out because I wanted to get off methadone because I don't abuse drugs, right? So I needed something like legit for my pain. So I went to another clinic and they gave me OxyContin.
Well, how much of that were you taking?
I was taking 5 tabs a day.
Okay.
And another, they also, I have it written another list somewhere. I don't remember, but I can give you that at some point.
Okay, that would be really helpful.
Anyway, they also gave me Lortab too, which was
I'm with the OxyContin, on both of those.
yeah.
Okay, that sounds like quite a.
And also, I just wanted to mention that I have last time I was at the ED, they told me I have an abnormal heartbeat.
Oh,
so
did you get a KG there?
Actually, I didn't make it to that, but I did get my last MRI. They looked at my heart and they said it was fine, but it always feels like I'm like having a heart attack. Yeah, I mean, I always feel like my heart's racing, and I feel really nervous right now because this is hard for me to be sharing all this stuff with you. But
so, what do you do maybe that helps to calm you down or give you some kind of pleasure in your life?
well, I mean, I used to volunteer, but I can't really do that anymore because I can't leave my home. I have a lot of anxiety, I've got agoraphobia. Sometimes I'll just be like stuck there for days. I feel suicidal a lot.
Okay, wow. Do you feel suicidal today?
Well, yeah, I feel it almost all the time. So I have a lot of trauma and stuff. So.
Have you met Lydia? Behavioral health?
Oh, no, I've got a counselor and I've got the psychiatrist, so they prescribed me lorazepam and Klonopin. To another person about it, that seems to be like kind of ridiculous, so.
Yeah, no, I hear that you've got some other supports there, but here at our clinic, we really
work as a team to try to understand how all different parts of our experience affect our pain. So why don't you just sit tight for a sec? I'm just gonna pop out and get Lydia. She's gonna be super helpful to us here. So just sit tight. Oh,
Thanks for your patience. So I'm going to hand it over to Lydia now to show how you can really make a difference.
Oh gosh, well, I don't know if I'm thrilled that it went at the end because I think it actually fit really well, or if I'm horrified because now I have to come after that. So I'm the Lydia that Rachel refers to in the video. I'm a behavioral health provider at Old Town Clinic, and like Rachel said earlier, we sit on the same team and we share some of the same patients, and so we see these often multifaceted patients where just a 20-minute exam room visit isn't going to do much of anything, right? And so what I want to talk about today is sort of the third leg of the multifaceted piece that Rachel was talking about, which is the history of trauma piece. And someone asked the question, what is trauma-informed care? And I'm sorry to say that I'm not going to give you a definition today, but what I want to offer next is sort of this conceptual understanding of the neurobiology of trauma that sort of lays the foundation for trauma-informed care. Someone asked me once if trauma-informed care was a fad, and I was like, well, maybe, but I think where it's coming out of is that we have all this new understanding of how trauma affects the brain, and so it's not a fad because we have new scientific knowledge, and so it means that our care now needs to reflect what we know about the human brain. And so again, what I want to offer is a conceptual and a very experiential little talk on the neurobiology of trauma. So just a couple things that are going to mimic some of the things Rachel said, but I think are important enough for me to repeat. And the first is just a little piece about brain plasticity. So what you see up here is neurons, and then a little map of Forest Park. So our brains literally are like natural park areas, where the more we utilize a certain area, that part can grow. The more we don't walk on certain paths, that part of the brain can be grown over, can get old and dusty sort of. And then literally, if we overuse certain parts of the brain, they can become injured, as we'll see in trauma. So just keep that in mind as we move through this, that brains are very plastic things. They can change based on our experiences. The next thing that I want to sort of drive home, and Rachel talked about this a lot, but is this sort of differentiation between the prefrontal cortex and then the limbic system. So in interpersonal neurobiology, they refer to it as upstairs brain and downstairs brain. So upstairs brain is the medial prefrontal cortex, and that's really where we have our personality. It's where we do all of our critical thinking, and it's where recovery work takes place. You have to have medial prefrontal cortex online to do any recovery work, whether it be trauma, addiction, chronic pain, etc. And then the downstairs brain is the limbic system, and that's where we've got the nucleus accumbens. It's where we do all of our reward behavior. It's where we also do all of our safety behavior. So that fight or flight system exists there, and I know you all know this, but I just want to highlight it because it's so important for looking at these this triad as a whole. And so keeping that in mind, I want you to just sit in your chair for a second and think about what it feels like when you're driving down the road, walking down the road, riding your bike, look in the rearview mirror, and there's a cop in the rearview mirror. So just sit with that for a second. What happens in your body? Feel free to pop some things out. Anxious. How do you know you're anxious? Your heart rate. Okay, your heart rate goes up. Hold still. Freeze. Okay, some people feel like they freeze. Yeah, what else?
Start running.
You start running? Okay, so if you're not in the car, you might start running. Okay. What else?
Squeeze the steering wheel.
Squeeze the steering wheel? Yeah, absolutely. Your muscles get more tense, definitely. What else? A gasp? Okay, does your breathing change a little bit potentially? Yeah. Start swearing a lot. Okay. We now know this guy in the back swears a lot. Okay. I swear a lot too, it's okay.
I pay attention to the cop much longer than I need to. Like, he'll be 2 blocks behind me and I'll still be looking at the rearview mirror.
Oh, interesting. So one part of your brain is really, really kind of on it. All of a sudden you're paying attention to the potential threat. And yet what if I knocked on your window and I said, hey, multiply 8 by 8 and subtract 2. Could you do it? Yeah? Wow, I'm impressed. Okay, I'm gonna cheat with you on my next math test. Because I couldn't do it. I don't think I could do it right now, standing up here. But in general, people will notice that one part of their brain kind of goes online and another part of their brain sort of goes offline, right? So we know what this is, and all of you should probably know this pretty well. This is the beginning of fight or flight. This is our body's stress response. And there's all kinds of cultural differences in how we respond to stressors, but ultimately, physiologically, stress looks the same for all of us, with some variations. So what's actually happening anatomically is the amygdala. So we're in the downstairs brain. The amygdala is the thing in the downstairs brain that says, hey, that thing is a stressor or a threat. That's the thing that you need to watch out for. So the amygdala says, okay, let's attach the idea that there's a threat happening, and let's turn on the fight or flight system. Amygdala, of course, turns on the HPA axis. Most of you in this room, I don't even need to review this. It should be sort of etched into your brains at this point. So HPA axis, of course, hypothalamus, turns on all of our sympathetic fight or flight neurons directly, but then it also sends that message down to the adrenal glands. And then the adrenal glands, of course, squirt out catecholamines, norepinephrine, epinephrine, and that's what gets that physiological response that you all had when there was a cop in the rearview mirror. It's those catecholamines and that sympathetic neuron stimulation that allows for those experiences. And so you guys know all of these. You know, most of you are using things like Sudafed in clinical practice, and so you know exactly what happens when you do that adrenergic stimulation. And yet the one thing that I think that we often don't think about enough is what happens to the brain during that sympathetic stimulation. So just think for a second again, someone brought this up, but think for a second again, cop in the rearview mirror, think about how your brain is functioning in that moment. Just sit with it for a second. So what we actually know is that when people are under adrenergic stress, they usually lose about 30 IQ points. I mean, it's relative, but people actually become a little bit less smart. And so what's happening is that you're literally getting less energy, sort of going to that upstairs brain or that medial prefrontal cortex, and you're getting a lot more energy in your limbic system. So when people are stressed out, they literally have different way that their brain is working. And often we're not thinking about that. So the next thing, of course, that happens under stress is we squirt out little bits of cortisol. And again, this should be something that's pretty sort of review for all of you. And yet it's important that we think about the long-term effects of cortisol, specifically when we're talking about trauma. So as we know, having a childhood history of trauma really changes the health outcomes that we see in adults, right? Someone later is going to talk a little bit about the ACEs study, which I hope most of you are familiar with. And so what we know is that having a childhood history of trauma, and partially because of this excessive cortisol that gets excreted in stress, our bodies actually change over the long term. So our physiological set point is different, and we call that allostatic load. So when we have allostatic load going on, we know that there starts to be some kind of immune system dysregulation. I don't want to say one way or another because it's different for everyone and different at different points in the stress response, but we know that people have immune system dysregulation. So what are some of the things that we know? You guys feel free to just chime in here. What are some of the things that we know are sort of consequences of immune system dysregulation over time with hypercortisolemia? Nothing? Yeah. Autoimmune disorders can be, yeah, absolutely, yeah. And the things I was thinking of when it comes to immune dysregulation, we know that there's some inflammatory illnesses, right? We know diabetes is an inflammatory illness. We now know that depression is an inflammatory illness. We know that heart disease is an inflammatory illness. We also know that long-term hypercortisolemia sets us up to be at higher risk for certain types of cancers. So there's a stress-cancer relationship. Some of the other things that happen is, again, we have hyperglycemia with hypercortisolemia over time, and I already mentioned diabetes, but we know that folks that have a history of childhood trauma are much more likely to develop diabetes later in life. And then I'll be fully transparent about the section on neural pruning of dopaminergic dendrites. So I've been unable to find a great citation for this, but whenever you see a trauma-informed addictions talk, people will talk about how there's some kind of changes that happen to dopaminergic neurons And what they think happens is that people with childhood trauma, that hypercortisolemia increases so much that it actually shifts how kind of exciting dopaminergic substances are to the nucleus accumbens. So like one bowl of ice cream for one person might do it, but for a person that had changes to those dopaminergic, and I'm talking about the D1 here, those neurons, maybe you need 5 bowls of ice cream to get the same amount of pleasure. So we think that there might be a relationship between addiction and chronic stress as well. And then the other thing that we know about chronic hypercortisolemia is that there actually are epigenetic changes to serotonin receptors. So something happens where we're more set up, and again, it's about inflammation. Something happens where we're more set up to have depression when we have long-term stress going on. So what I just reviewed was some of the long-term health implications of high stress levels. And yet what I want to sort of move into now is trauma. So when does stress become traumatic stress? So I'm just going to use a quote from Bessel van der Kolk. He's kind of the godfather of neurobiology of trauma. Totally lovely man. Newest book out is on the bibliography here, and definitely well worth a read if you want to understand trauma-informed care. So what Bessel van der Kolk says is that trauma is the result of exposure to an inescapably stressful event that overwhelms a person's mechanism. So what he's saying is that stress becomes traumatic when essentially the nervous system becomes overwhelmed. So let's look at what that actually means. And this is where hopefully we'll move into some things that aren't review for you guys. So what we know is that under stress, cortisol levels increase. They're going up and up and up. And part of the negative feedback loop for cortisol is the hippocampus. So CRF is going up, cortisol is going up, and then the hippocampus, which again is in that downstairs brain, the hippocampus is the negative feedback loop that's responsible for saying, whoa, dude, we have enough of that hormone going on. You can turn off the system. Turn off the system right now because we're good, right? It's just like a thermostat. You set it at 70, and then the heater brings the heat up to 70. When it hits 70, the thermostat tells it to turn off. Exactly the same deal. So the hippocampus is the thermostat for cortisol. It says, okay, we're stressed out enough. Please stop making this system. Please stop doing this, essentially. And yet what happens is when people have chronic hypercortisolemia or potentially even large bursts of stress, the hippocampus, the neurons in the hippocampus literally atrophy, their receptors get overwhelmed, and the hippocampus shrinks. So this is where we really see the neurobiology of trauma being different than stress, because what happens is when you take brain scan of a person diagnosed with PTSD, and mostly in these scans they're looking at military veterans, you'll actually see different hippocampal sizes or different volumes is how it's usually talked about. And so remember when I talked about how plastic the brain is? So that hippocampus volume actually decreases in response to a stressful life experience or to some kind of life experience. And yet, what does that mean for folks that experience trauma? Now remember that hippocampus, it's the negative feedback loop. So it's the off button for this entire system. So what that means is for people that have experienced trauma and they have that smaller hippocampal volume, is that the off system for the stress response is broken. So I want you to just sit for a second and think about if there was a cop in the rearview mirror and there was no off system in your life. So most of you probably utilize your medial prefrontal cortex and you do some kind of self-soothing to take away those stress hormones and that stress experience. And yet for folks that have PTSD, that self-soothing often doesn't work because remember, the medial prefrontal cortex is no longer online when the adrenergic system is stressed out. So here's the neurohormonal profile of trauma survivors that we see, and this often really surprises people. So what you'll see is that there's an increased CRF, so that mimics, of course, chronic pain and also addiction. So we've got increased CRF, and then we've got increased norepinephrine and epinephrine, so we've got that increased stress response. Again, that mimics chronic pain and it mimics addiction. And then here's the one that usually surprises people, because I just talked a lot about chronic hypercortisolemia, right? And yet when we have trauma survivors, they actually have decreased cortisol. And so what we think has happened is that the adrenal glands have they've essentially been over-resourced. So cortisol actually decreases, which again is part of the thing that says turn off the stress response. So kind of both of the mechanisms that say, hey, turn off stress, become broken. We no longer have cortisol, and now we have a smaller hippocampal volume. So what that means is folks are running around with a cop in the rearview mirror, essentially all the time. So let's talk about how that might show up in clinical practice, or some of the implications that we might see. So first of all, as we've talked about, hopefully we've kind of nailed this point is that there's this decreased involvement or decreased control of the prefrontal cortex. And so I don't want to say that the limbic system is dumb. I don't want to say that. But the limbic system is not very good at it's very good at generalizing. It's not very good at doing specifics and at doing really complex thinking or engaging our personality. So what we often see in clinical practice is folks that are having a harder time doing some of that complex thinking. Their personality may seem offline, and it feels like they're really driven by those things that, again, as Rachel was talking about, that decrease that experience immediately. So instead of sort of having that ability to self-soothe and that ability to do complex thinking, they're sort of driven by this other place in their brain. The other thing that happens when we've got some hippocampal damage is that there's usually significant memory change. The hippocampus is kind of that muscle that does memory. And so we see memory change, it can vary and look different in different people, but we often see memory change, and especially we see memory change where people have a hard time sort of inserting themselves into their own self-narrative. So oftentimes with people that have experienced trauma, you'll actually see people experiencing a hard time having sort of a sense of self and understanding themselves in this kind of larger narrative of life. And of course, in trauma, we also see difficulty accessing rest and repair, right? If fight or flight is always turned on and the mechanisms for fight or flight are broken in some way, then it's very, very difficult for people to access true rest and repair, which of course shows up in chronic pain tremendously, as many of you know. And then the things that are increased in trauma is we have increased hypervigilance. Again, just remember having a cop in the rearview mirror and what that experience would be like kind of on a daily basis. So we've got increased hypervigilance and startle response, increased emotional dysregulation, because again, that medial prefrontal cortex is what allows for emotional regulation. Our emotions, in trauma, emotions can often run amok because that medial prefrontal cortex isn't doing the sort of conversing from the upstairs brain to the downstairs brain. And when we think about those neurons, they talk about this a lot in interpersonal biology, those neurons from the medial prefrontal cortex, they're very fancy, like Rachel said, and they're very, very slow. So it's literally like a bicycle on a dirt road, whereas the downstairs brain, the limbic system, it's like the Autobahn. And so unless you have a lot of attention up here in the medial prefrontal cortex, it's very easy for the downstairs brain to really take control. And then finally, the thing that you often see in clinical practice with folks that are trauma survivors is this increased bottom-up perception and decreased bottom-down perception. And really that's a fancy way for saying that people that have experienced trauma are very good at feeling things coming at them from the outside. So it could be pain, it could be external stimuli. Oftentimes trauma survivors have increased startle response to things like sounds, or have a harder time with clothing, often feels uncomfortable for them. So they're magnets for all of this stimuli coming in this direction, but they have a really hard time creating a narrative, creating stories to put out towards the world. And so you'll often see that in some way in clinical practice. And so to summarize the neurobiology of trauma, and again to kind of look at the way in which it overlays with chronic pain and addiction, the neurohormonal landscape of trauma, addiction, and chronic pain mirror each other. There's increased CRF and norepinephrine. And if you ever need to sort of have a reminder of that, just think about that cop in the rearview mirror. Think about what that experience is like. There's significant executive function impairment. So for all three things, trauma, addiction, chronic pain, and I hope that I don't want this to be read as me saying that people that experience addiction, chronic pain, and trauma aren't smart, because it certainly could be read that I'm saying that. And that's not at all how I want to be read. What I want to be read is it's hard for these folks to bring the medial prefrontal cortex online and to utilize it in a way that sometimes fully benefits them. And then with that executive function impairment, there's this promotion of relief-seeking behaviors from negative affective states, regardless of what that means for the future. So just like Rachel was talking about, oftentimes people, because of that decreased medial prefrontal cortex engagement, what we see is that people will just grab for the first thing that makes them feel good. And it's really hard to think about maybe 6 hours later or tomorrow. All right, do you think this one will work? Okay. So we have another video. It's not nearly as funny as the first one. Sorry, I will just let you know right now. So what you're gonna see in this video is this is the same patient coming back. So remember, Rachel referred her to me with behavioral health. I've seen her a couple times, and we're just starting to do some really beginning work around decreasing her benzodiazepine dose and then building up some skills for resiliency around trauma.
Last time I saw you and we had that very slight dose decrease in your Klonopin.
I still felt really anxious. I mean, I guess maybe a little bit, but still, I still feel really uncomfortable.
Okay, okay. And so do you feel more anxious than you did before decreasing the Klonopin?
It's hard to tell. Maybe, I don't think so, but it's still really bad. I mean, I feel it's really hard, so.
Yeah, okay. And yet it sounds like it's not a whole lot worse than when you were taking the Klonopin. And so maybe the Klonopin wasn't helping quite as much as we thought that it was.
I don't know, maybe.
Okay. You know, you actually seem a little bit anxious to me today, right now.
Yeah.
Sometimes talking about decreasing medications or changing medications can bring up a lot for people. So I'm wondering if it would be useful just to do a little bit of grounding right here in session with me.
Okay.
Okay, great. So what I want you to do then is just kind of sit as deeply into the chair as you can, and I want you to put both feet on the ground. Really open your shoulders up, and I want you to put your hands right at the bottom of your back behind.
Like this, or?
Yeah, and just kind of press into the bottom of your back. Great.
It feels awkward.
Okay, well, make sure you're comfortable.
Okay.
So get comfortable in the chair. And then I just want you to take a couple deep breaths. And if you would for me, count as many red objects as you see in the office. How many did you get?
5.
Okay, great. And how's your anxiety?
I guess fine.
Oh, okay, interesting. So that seemed to help a little bit with anxiety. And how about your pain? How's your pain after that little grounding exercise?
I guess I forgot about it for a minute.
Okay, great.
Yeah.
Interesting. So you found that you were actually able to distract yourself for a second.
For a minute, yeah.
Okay.
Yeah.
Okay, good. Well, that helps us bring us to some things that I've been meaning to talk to you about. And the first one is that I'd really like to make a referral for you to see someone who does more than just medication management. So when you have a diagnosis of PTSD, which you have, as well as a couple other things, you know, medications are really just a tiny piece of the pie. They can really only go so far. And so we really want to focus on building up the non-anxious parts of your brain. So PTSD lives in this one part of your brain, and I want to help refer you to someone that's really going to help build up the non-anxious part of your brain and kind of get that non-anxious muscle part of your brain working better. So his name is Anderson, and I think you're really, really gonna like him.
Okay, I mean, honestly, like, Rachel, my doctor, told me I had to see you in order to continue my medications, my pain meds, so whatever I need to do.
Okay. Well, and my commitment is to have you feeling as good as possible with as few medications as possible. Really, we want you feeling good, but for the sake of PTSD, sometimes medications actually kind of do the opposite of what we want them to.
Okay.
So in the case of Klonopin, we've been going down a little bit, and today I'm going to ask us to go down a little bit more. Now again, I know this is going to be real anxiety producing, but what happens in PTSD,
I need for you to understand, like, I might not be okay.
okay,
So I can't have that taken away from me.
yeah. And I
I tried
really,
to tell you that when we met, like, I tried to explain that to you. So when I don't know, like, you can't take it away. So
okay.
I won't be okay.
Okay. Well, your safety is my biggest concern, and so we're not going to take away the medication. Absolutely not. But what we might do today is we might go down just a little bit, because we were able to go down a little bit last time, and it seemed like your anxiety didn't necessarily get worse. Now, your anxiety might not be a lot better at this point, but your anxiety certainly didn't get worse.
Okay. Yeah.
Yeah. And so for the referral I'm going to make to do some psychotherapy. Now the issue is that in PTSD, actually the Klonopin at the doses you're taking makes that psychotherapy not work. So when you take Klonopin and you have a diagnosis of PTSD the way that you do, it actually turns off your whole central nervous system. And to do the therapy and to have that therapy work, we need at least a part of your central nervous system to be engaged in the therapy. So there's other medications for treating PTSD that turn off just the part of your nervous system that are kind of out of whack in PTSD, but that don't turn everything off. So I think it's time for us to turn to those medications and then really build up that non-anxious part of your brain, and then try to pull back on those medications that make it so it's harder for that therapy to work. So I just threw a lot at you.
So I'm going to stop the video a little bit early since we're running out of time, because I want to make sure you guys have time for questions, and also to move through just the last little bit of Rachel and I's talk. So just real quick, I wanted to spend a little bit more time on this, but I think because of our video malfunction, we're running late. So what you saw me doing in that video was a grounding exercise where I had her counting things, which is kind of a basic activity that we do, sort of pre-mindfulness activity. Oftentimes when folks have a pretty significant history of trauma, if you immediately start asking them to do mindfulness activities, it can actually sort of backfire on you. So what you see in that video is a grounding activity. And so I just want to do a quick review of things that are appropriate when people have a history of trauma. So there is some appropriate psychopharmacology, although trauma really is, when we look at the treatment for it, psychopharmacology is not sort of the pinnacle. Prazosin often can be useful in decreasing nightmares and some of that daytime hypervigilance, but really what you need to do is the therapy. And I'm going to leave this for Anderson to review. But when we talk about trauma-specific treatment, we're really looking for things that are body-centric. So we're looking at for somatic therapies; those are considered to be the pinnacle of treatment for people with a trauma history. And then some of the things that we shouldn't do is we really shouldn't set up our systems for re-traumatizing patients. Little tiny things like discouraging patients from being late. Often when people have trauma, time management is particularly hard for them. So when we set up systems that don't allow folks to show up late, although that's often very difficult, that can be sometimes re-traumatizing for folks. We definitely don't want to include shame. These seem pretty obvious. But the thing that that I do want to spend a second on here is allowing for loose boundaries with our patients. And I think that the first talk today really set this up well, which is that oftentimes people will say, oh, trauma-informed care, that's where we're just really nice to our patients, right? Like extra nice. And the way that can sometimes look is that what we lose is really is strict boundaries. And boundaries actually make our care safer for the patients and make it safer for us. And so I loved the morning talk where we talked about providers really saying, hey, I know you can do this. We're going to do this. I know you can. That's having strict boundaries instead of saying, well, maybe this one more time we'll just continue this dose where it is. And then, as I think we sort of have nailed in, inappropriate psychopharmacology for trauma is benzodiazepines. So it may help immediately with the hypervigilance, but in the long term, it's really, really not useful. And if anything, it's actually detrimental to recovery from trauma. All right, I'm going to quickly turn it over to Rachel.
Okay. So just the last few things we wanted to try to bring this back around. We started out talking about the neurobiology of pain and addiction, and then trauma and treatments for trauma. And I want to come back to, okay, so if we have these models around rapid relief seeking, particularly in chronic pain, what is an approach to therapy that makes sense? And again, we've got Thomas will talk in a little bit, and Nora as well about about the specifics. But here's the broad framework, which is basically that in both chronic pain and addiction, the healing process involves increased recruitment of that D2, that inhibitory pathway. You basically want to give people just enough dopamine to activate those D2 receptors, not give them, but you want to enhance enough dopamine in their systems to activate those D2 receptors, get a little bit of inhibition, but not enough to knock them out altogether. So the idea is sort of consistent low-level dopaminergic input to build back that inhibition. And the idea here is that you look at lots of tiny opportunities for little reward. What are little things that release little amounts of dopamine? Making somebody laugh, walking to the mailbox, playing a game with the child. Again, Laura talked about this a lot, of what are all the small things when you're talking about pain with the patient? What are all the small things in life that make it worthwhile? And not only do they make it worthwhile, they allow your D2 receptors to activate, allow your brain to slow down a little bit, and give your frontal cortex enough time to make a choice. It was really funny. A few years ago, I had a patient. He was sort of a weird guy, and he was in early recovery. He said to me, every time I do 50 push-ups, I receive 8 units of dopamine. And I was like, what? I'm like, what? And then looking back, I'm like, you were right. Like, who am I to disagree? Really validated. So what might this mean practically? Again, basically the chronic pain and addiction, as Lydia talked about trauma, it really is the same brain healing process. We want to reduce exposure to huge dopamine signals, reduce exposure to things that give you that quick relief. So to the best extent you can, limit use of addictive drugs or medication. If you have access, if you're able to give your patients access to healthy food instead of junk food, that will prevent big surges in dopamine. Avoid fast-acting analgesics, work on tobacco cessation. If somebody does need some sort of opioid agonism, buprenorphine or Suboxone really is a reasonable choice. It's a low-level, steady dopaminergic input, as opposed to some of the bigger surges we might get with full agonists, and particularly fast-acting ones. We want to prevent the desensitization of that D2 pathway. And at the same time, as far as the things you don't want to do, the things you do want to do, again, is increase as much as you can that exposure to small reward. Things, again, very similar to trauma: social reinforcement, problem solving, effective emotional coping, small goal achievement, particularly related to movement and activity, which Nora will talk more about. All of these will increase that activity of the D2 pathway, build back that low-level inhibition, allow your frontal cortex some time to step in. And with that, I think we're done. Yeah, okay. Thank you. We have a few minutes for questions, I think. I think if we both turn them on, it'll explode. So we can take a few questions, and then there's a break coming up as well.
Run this around to anyone, encourage you to ask, or are people ready? Hi. Are there any interventions that have been shown to be effective in minimizing the development of PTSD if you're seeing a patient who's just recently experienced a trauma?
So there was some research a couple years ago about propranolol given just a couple days after a traumatic experience, sort of preventing PTSD. As far as I know, it's not used wide in clinical practice, and I think not used widely in clinical practice, and I think didn't give us as much benefit as we were expecting it to. And other than that, I don't know of any research addressing that.
You brought up the small things and small activity, but I think of some of my patients who have dealt with these past histories and traumas, and they are ultramarathoners or super athletes. Do you know of any history about that, or research about some of these athletes and their dopamine and how it relates to this?
That's interesting. What that makes me think of actually is something that I think Thomas will talk more about, which is exercise as one of your body's own natural analgesics. Mm-hmm. And these may be people who have sort of chronic pain trauma, sort of a combined chronic pain trauma syndrome, and have adapted to their pain response in particular using exercise for analgesia. That's the first thing that comes to mind. I don't know if you want to think about it from a trauma perspective.
I think I would conceptualize it in a similar way, which is that folks are sort of gaining their own endorphins and their own dopamine to make up for the potential loss that trauma exhibits over a long period of time.
And I do think exercise, again, you can have small amounts, but I think as something that's sort of, I wouldn't think of it as something that's causing a massive dopaminergic surge. I mean, I do think probably, particularly if you're doing it steadily over whatever an ultramarathon is, 100 miles, 16 hours, that is sort of low-level reward stimulation and not massive. Not that sprinters are dopaminergic surges, but I think it speaks to that same idea of sort of a low-level constant release of a reward transmitter.
Do you have any information about adolescents, like if they're addicted to video games, can that contribute to some of this circuitry going out of balance?
Yeah, so what we know about behavioral addictions or process addictions, and this comes straight out of ASAM, the American Society of Addiction Medicine, is that all addictions involve the same neurocircuitry and the same sort of pathophysiology. And so regardless of it being opiates or sex or video games, when people engage in these behaviors in a way that's addictive, where that behavior sort of garners more control in their life, it has the same implications. Yeah.
How useful is the sort of reframing of pain? We started the day talking about the shift, the paradigm shift, and I think we didn't really call it out, but the shift is sort of the shift from addiction being a moral failure to being a physical health condition. Mm-hmm. So how useful is that in terms of talking to patients, helping them shift? Mm-hmm. I mean, I think that it's very complicated even for healthcare providers. Mm-hmm. So have you found effective ways to help people deal with their own feelings of shame, how they think about themselves, how they think about their biology, how they think about their pain?
Do you want to start?
Sure. I loved the VIMA that was offered earlier. Am I getting that right? Validate, educate. The one thing that I have found in my clinical practice is as much education as I can give people about sort of the neurobiology of addiction. It can often be so liberating for people to start to really understand how this functions in their own life. So I did a couple years of doing co-occurring trauma and substance abuse groups. So I did a group called Seeking Safety at the clinic, and watching participants in that group understand the pathophysiology of both addiction and trauma was probably one of the more liberating aspects of that group for most of the participants.
And then as far as the pain management, we're really lucky to have Nora Stern here, who will be talking this afternoon specifically about pain education and using particularly sort of conceptual models as well as certain types of language that help to de-threaten pain, to de-threaten movement. I think as far as one grand unification theory that wraps all of these things up together and how you can have one explanatory model, I think maybe that's our work for the future.
Let's take one last question and then we'll take a break.
You had mentioned in some instances practices are counterindicated. Could you speak a little bit more about that, and also draw the distinction between a mindfulness practice and, say, what a grounding exercise may look like?
Sure,
Thank
yeah,
you.
that's a great question. So I would say in general, it might be a good idea to leave the mindfulness practices in part to the behavioral health providers. Folks that are fluent in trauma will often have a good sense of when someone is ready to sort of be in their body, and when asking them to be in their body and practice mindfulness is actually going to be counterproductive. And the distinguishing factor between grounding and mindfulness is that grounding is asking people to distract themselves for a period of time. So it's when people are very sort of emotionally dysregulated, and what you want is to get them out of their limbic system. What you're going to do is ask them to do grounding things. And when someone is potentially a little bit more advanced, been doing grounding for a while, or potentially not as emotionally dysregulated, you can start to incorporate more direct mindfulness. And even often beginning mindfulness is distraction techniques. And so it's kind of a continuum, but I think my suggestion is leave the intense mindfulness work to the behavioral health providers.